Good afternoon and welcome to another installment of Bingham Healthcare's Be Informed webinar series. Thank you very much to everyone who's joining us today on Facebook, on our Facebook Live post. And I'd actually like to introduce our doctor who's going to be talking to you today and answering your questions. We have Dr. David Sissel. His specialty is urological care. He's a urologist, and he takes care in treating managing kidney, prostate, and bladder disorders. Welcome, Dr. Sissel.
Thank you, Michael. Happy to be here.
And thank you again for everyone who is with us today on Facebook Live. I'm Michael Brandis. I'll be your host today. For those of you who are watching either live or watching this video after it has been posted, please feel free to leave questions. Our social media team is always managing our Facebook pages. So if you send in questions, we'll try to answer them during this live webinar, but we will also answer them after this webinar has aired. So please feel free to submit your questions at any point, and our social media team will get those to Dr. Sissel, and we'll be more than happy to respond to those as well. Dr. Sissel, maybe you could tell us a little bit about yourself, perhaps a little bit about what is it that inspired you to go to medical school, and what is it that inspired you to actually ultimately specialize in urology?
Sure, thanks, Michael. So I grew up in Chicago and went to college in Chicago. I studied anthropology because I liked it. It wasn't pre-medical in any way. I just found what I liked to study. And it really wasn't until the end of college when I had an experience where I thought I could really help people in medicine, and that was during a study abroad trip to Tanzania and East Africa, where I saw a number of people with different disorders, mostly infectious disease related, HIV, TB, leprosy, things we don't see here as much. But I really felt like I could make a difference with those folks. I was there studying paleoanthropology. We were working at an ancient hominid site, and really I just had a revelation. And so I decided to pursue medical school, and that took some time. So I did that in Boston over the course of 4 years, and then was fortunate to be accepted back at the University of Chicago for medical school, and spent a good 5 years there, and then moved on to California, San Diego, after I decided to pursue urology.
That's fantastic, Dr. Sissel. I really appreciate you elaborating on that. Maybe you could talk a little bit about urology, and maybe talk about some of the more common things that you treat and diagnose for patients who come in to see you, just to let people get to know a little bit more about what urology actually is, because I think there's a lot of things that maybe gets confused with, and so maybe you could kind of shed some light on that.
Sure thing, Michael. Thanks. So a urologist deals with all disorders of the kidneys, ureters, bladder, the pelvis, prostate, penis, testicles. That's really everything we treat, and that includes kidney stones, that includes cancers of the urologic system, which are kidney, bladder, testis, prostate primarily. So we also treat, just to be more specific, erectile dysfunction, low testosterone. We treat women with incontinence. We treat women with prolapse. So it's quite an array of different disorders. And that's what I see as a general urologist. Of course, many urologists are more specialized, but I kind of do it all.
Okay, excellent. Thank you very much for elaborating on that. So just to let all of our viewers know, the first thing to let you know is that Dr. Sissel actually he works for Brigham Healthcare, and he actually sees patients at our comprehensive cares clinic in Idaho Falls, which is off of Sunnyside Road near HIT. And he also sees patients throughout the week in Blackfoot as well, at 98 Poplar Street in the medical office building, or it's also referred to as the Idaho Physicians Clinic. Dr. Sissel sees patients there as well. There will be phone numbers listed at the bottom of the screen. So if you would, if you'd like to schedule an appointment, or if you would like more information, you can call that phone number. You can also visit our website, binghamhealthcare.org. binghamhealthcare.org, and you can find additional information about Dr. Sissel and where he sees patients and his office address and things like that. So the other thing that I'm going to start doing is before this webinar aired, a lot of people submitted questions. So we're going to be answering some of those, or I'm going to be asking Dr. Sissel some of those questions. And then if you're engaged in watching this live, again, please feel free to submit your questions in the comment section, and we will try to get to those questions today. And if we don't, we will be sure to follow up with you directly. We'll send you a direct message on Facebook with a response to your question. Excuse me. The one thing that I would like to make a mention is that Dr. Sissel is going to be answering questions today. Just to let you know that is not to be taken as a diagnosis. It's more of a general response to the questions that have been submitted. But to receive an official diagnosis or treatment, you will need to schedule an inpatient visit and visit with Dr. Sissel so that he can thoroughly assess you and come up with a proper diagnosis that way. So this is just more informational today. Okay, so one of the first questions that a viewer has actually submitted, Dr. Sissel, is they say, I have been having severe back issues, which were thought to be kidney stones, but none were ever found. When I'm having them, I lose complete control over my bladder. It's not minor leaking, but like my water broke like when I had my kids. Sometimes I don't even know I need to go, but when I stand up, that's all it takes. Is this normal for a 45-year-old female? Should she be concerned? And what can you do to fix or help it to be somewhat better?
Thanks, Michael. In all likelihood, this is within the realm of normal for a 45-year-old woman. The back pain is something that may be unrelated. I'd have to look at the imaging that she's had to really get an idea about what the back pain might be from. The incontinence, though, is something we commonly see in women, and we do see it in men. They're a bit different in the two genders, but this is likely a type of incontinence we call urge incontinence, also known as overactive bladder. It could also be stress incontinence. So I'd have to ask this lady a few more questions about her history to really get an idea and give my recommendations. But this is within the realm of normal. There's always a possibility that this could be an outlier and it could be a harbinger of something more serious. But these are all things I would ask about in my appointment and get to the bottom of.
Okay, thank you, Dr. Sissel, and thank you to the person who submitted that question. I hope Dr. Sissel has been able to elaborate on that for you. And again, if you would like to schedule an appointment, he does take self-referrals, so you can either call and schedule an appointment with his office, or the other path that a lot of patients take to see Dr. Sissel is after they've met with their primary care doctor, then they are referred by that doctor to Dr. Sissel. Okay, the second question that someone has submitted is related to prostate cancer, Dr. Sissel. But I think the first thing that maybe I want to take a step back is I think what's important to know is that as a urologist, Dr. Sissel does not perform prostate exams. That would actually be done through someone else. But then, is that correct, Dr. Sissel? Then you would actually be able to work with a patient who does have prostate cancer after it's been diagnosed.
No, I do diagnose prostate
Okay.
cancer. I do prostate exams on a regular basis.
Oh, okay.
I don't do colonoscopies. That's something performed by a gastroenterologist or a general surgeon. But I do everything related to the prostate. To answer your question.
Okay, great. Thank you for clarifying that. Okay, so the second question that someone has submitted is, can I do anything to lower my chances of developing prostate cancer?
That's a great question. So, and I wish I had a direct answer. As far as becoming diagnosed with prostate cancer, we really don't have strict recommendations that have been proven by data. We have various things that can guide us in answering a question like this. We know that prostate cancer is more common in North America and in Northern Europe among certain ethnic groups, and we know it's much less common in places like Japan. And the feeling behind that is that it has to do with diet. And some research has shown that phytoestrogens, a diet that's rich in phytoestrogens might decrease your risk of developing prostate cancer. But I don't want to necessarily give that recommendation because it's really not fully proven. So there is a link there. That's the main thing that I recommend for patients when they're asking that question. But what really is important is family history. There's a strong genetic link with prostate cancer, especially if a father or brother is affected. So that's really quite an important thing. We know that African Americans are more at risk for prostate cancer, as well as Jamaicans, especially. And so those are populations where I'm rather aggressive in screening. So I hope that answered your question, Michael.
That's great. Thank you very much, Dr. Sissel, and I hope that that helped the viewer who submitted that question. I did want to ask. I know that. Well, I should mention that September. That now that we're in the month of September, it actually is Prostate Cancer Awareness Month. And am I correct in saying, Dr. Sissel, that men dying from prostate cancer is the second most common form of cancer that affects men?
Yes, you're right, Michael.
Okay. So it's something that should be taken very seriously. And Dr. Sissel, what would you recommend as far as screenings? How does someone, how do men know that they should be screened for prostate? Usually around what age should they start talking to their primary care doctor about that?
That's a great question, Michael. So if there's no increased risk in a man's family or in a man, then it's important to start screening at age 55. I recommend screening from 55 to 69 with the exam, which is called the digital rectal exam, and a blood test called PSA, which is prostate-specific antigen. And that doesn't need to be done every year. Every 2 years is often okay, as long as the man's blood test result and his exam are both not concerning. But if there's an increased risk in the man because of his race, for example, if he's African American or Jamaican, or if he has a strong family history or a family history in general, then I would recommend screening a little bit earlier. And that's and as far as when, the answer to that is that's to be determined by a discussion between me and the patient. There's no strict age. But 50 is probably a safe place. We typically don't recommend screening for prostate cancer in any way under 40 because we haven't found that we discover more men with prostate cancer in that age group. 40 to 50, well, that's pretty questionable. I don't routinely screen men 40 to 50, but if the patient has a strong family history, say his father, for example, or brother was diagnosed at an early age with advanced prostate cancer, I may recommend screening a little bit earlier in life.
Okay, excellent. And I know it may be a little bit difficult to have a specific answer, but are there any warning signs or symptoms that a man might be experiencing that might indicate early on that there's something wrong with the prostate, or that there's maybe like in the early stages of prostate cancer? Are there anything in general that you would talk to people about, that they should talk to their doctor about if they're noticing?
Right. Thanks, Michael. Great question. So, prostate cancer, typically, if a man has it, he likely doesn't have symptoms. It's most often contained within the prostate, and it's not making him symptomatic. Once it's advanced, though, it can cause symptoms. Prostate cancer likes to spread to the bone, including the spine and pelvis, and then a man might develop back pain or pelvic pain. And if it grows extensively within the prostate gland, he may develop some urinary symptoms that are suggestive of some blockage. So that's as far as prostate cancer goes and symptoms. But with our other disorders having to do with the prostate, specifically BPH, which is benign prostatic hyperplasia, or enlargement of the prostate that's benign and not cancerous, those men often present with symptoms that are bothersome. They're urinary symptoms like having to go to the bathroom often, get up at night frequently, having to get to the bathroom quickly, not feeling like they empty completely, stopping and starting of their urinary flow. Those are symptoms suggestive of some sort of blockage, which is oftentimes the prostate in a man who's, say, 50 years or older. And so all these things I would flesh out with the patient at the time of the appointment, and then we'll come to a sort of an answer as far as my recommendations go.
Okay, excellent. Thank you for shedding some light on that. The third question that someone has submitted is, how do I know if I have erectile dysfunction?
Good question, Michael. So erectile dysfunction is described as an erection insufficient for intercourse or the sexual activity that the patient engages in. So if a patient or a man is dissatisfied with his sexual life, then that's something he can explore with me. So it's really has to do with the patient personally, and there's no sort of strict criteria as far as erectile dysfunction diagnosis goes. It's really if a patient is dissatisfied with his erections in his sex life, then that's essentially erectile dysfunction.
Okay, excellent. And maybe to elaborate on that a little bit, I guess maybe it depends on the situation, or it depends on the man. But maybe are there a number of different ways that you actually treat erectile dysfunction?
Yes. So what we usually do at the start is make sure the man is essentially living a healthy life. We check cholesterol levels, make sure his blood pressure is controlled. Those are basic things that we can look at and attempt to treat and potentially help with his erections, as well as diabetes control. These are important sort of lifestyle issues that can be corrected and allow for better erectile function and less of a sort of a decrement in the erectile function. But after those sort of behavioral modifications are, say, unsuccessful, then we start to talk about medical management, and that has to do with what are called phosphodiesterase inhibitors. Those are the medications a lot of us have heard of, like Viagra, Levitra, Cialis. And so after a discussion regarding their side effects and whether it's the right choice for the man, then I often will recommend it and see how he does. After that, we have more options. If the medications aren't effective enough, we can go to things like what's called a vacuum erectile device. There's also what's called a penile constriction ring. And beyond those options, we get into injection therapy, what's called intracavernosal injection, where we inject a very potent agent into the erectile tissue before sex, and it's very effective for men. And beyond that, we can talk about surgery, and that involves placing what's called a penile implant, so that's pretty much erectile dysfunction management.
That's great. Thank you. Thank you so much. The next question that we have a viewer that they've submitted is, I have watched my dad have have super painful kidney stones. How can I avoid that situation?
Great question, Michael. So there often is a genetic link to kidney stones, not always. What I would do is simply talk to your primary care physician, make sure blood work is normal, blood chemistry is normal, and there's no sort of screening for kidney stones that's recommended. We simply begin treatment for kidney stones once they're diagnosed. However, there are ways to prevent kidney stones, even with genetic predisposition. That's really just having a healthy lifestyle, maintaining blood sugar control, exercising. Those sorts of things really can prevent kidney stones. We've actually seen an increase in the incidence of kidney stones in kids because of just poor diet, poor health. Just being healthy really is your goal here.
That's great. Is there any? I've often heard that there are certain foods or there are certain drinks, maybe perhaps sodas, that you notice that if someone are incorporating those into their diet on a daily basis, that actually they have more of a predisposition to get kidney stones.
Right. Well, good question, Michael. So I am not a fan of blanket statements of, decrease your soda intake or, decrease your intake of certain foods. What I like to do, if I have a patient in my office who is a stone former, and I always offer them a metabolic workup for why they form stones. Really what the whole sort of evaluation involves, say, the stone analysis. So if a patient passed a stone or had a stone removed at surgery, we have that analyzed chemically, and that gives some of the story. But then I like to have them do what's called a 24-hour urine study, and that really gives all the detail we need with respect to why the patient forms stones. So it's not until I have those two tests, if I can only obtain the 24-hour urine test because we don't have a stone for analysis, that's fine. It gives a great deal of detail as far as why a patient's forming stones, and then we can come to a conclusion about my recommendations. And that might involve increasing fluid intake, decreasing calcium supplementation, increasing something called citrate in the diet. Those are real common things that are involved in stone formation. So it's not that simple as what I often will tell patients at the outset. We really need to do some investigating.
That's awesome. I really appreciate that you tend to take more of a holistic approach and kind of really assess that it's individual based, that I imagine everyone is different, and that it's not a one size fits all. You can do this or you can do that. I appreciate that you look into what's going on with each individual patient. The other thing I was going to ask is, what are the signs? How would someone know if they have a kidney stone?
Yeah. So common symptoms include flank pain, which is pain in your side. Patients might have blood in the urine. Patients could also have what we call renal colic, and that involves nausea and vomiting and the flank pain. Fevers, along with those other symptoms I mentioned, are concerning. Some patients present with some urinary symptoms that are new. For example, increased frequency, increased urgency of urination. Men can even develop pain at the tip of the penis if the stone is down near the bladder in the ureter. So those are the most common symptoms, Michael. Okay,
thank you. The next question actually refers to GreenLight laser treatment. I know that recently you have been acknowledged as a center of excellence in urology. Your specific practice has been assessed, and you've been given that designation as the center of excellence. I was wondering if you could maybe talk a little bit about what that designation means to you, and then maybe transition into to start out with, before I ask this question, maybe talk about what is GreenLight laser treatment.
Sure. Thank you, Michael. So, GreenLight laser therapy for men with enlarged prostates is a form of surgical management. So, that's typically something we'll recommend if medical management is not working out for the patient, or the patient simply prefers not to be on medical management, or the patient has side effects from the medications that sort of disallow him from taking them. And this form of treatment involves an approach through the urethra under anesthesia using a scope called a cystoscope. And through the cystoscope, I use a laser fiber to vaporize the prostate tissue that's obstructing the flow of urine. That is the man's problem and the reason for his symptoms. It takes typically an hour, sometimes an hour and a half. There isn't a tremendous amount of blood loss. Patients do not need blood transfusions. They do go home after surgery, after recovering from anesthesia. I leave a catheter in the bladder for one night, and we then remove it the next day, and the patient's urinating on his own once again. It's not a painful procedure. I do give pain medicine to just make sure the patient is covered in case he does have some pain, but patients typically do not take the pain medication because, again, it's not a painful procedure. Patients can have symptoms after surgery like blood in the urine and some discomfort when they urinate. Those are symptoms from the surgery itself and not going to be prolonged in any way. But the patient notices improvement in his urinary symptoms right away after that catheter is removed. Some of the symptoms take time to improve, but some of them actually improve overnight. It's pretty impressive. So the Center of Excellence designation is something I'm very proud of. It has to do with a surgeon's volume, meaning how many patients he operates on or she operates on, and in conjunction with outcomes, which have to do with how well the patient does after surgery. We have a questionnaire form that we give patients before surgery and after surgery, and as long as those parameters that are asked about on the questionnaire improve in such a way, that surgeon is given this designation of Center of Excellence. And so very proud of that. I'm a huge fan of GreenLight therapy for the prostate because I know how well patients do afterwards. And so I'm quite proud of that designation, Michael.
Congratulations, Dr. Sissel, on achieving that.
Thanks.
I was going to ask, I didn't look into this before the interview today, but do you know if you're the only doctor or urologist in the area that uses the GreenLight laser treatment, or are there other doctors in the area as well?
So my partner, Dr. Sisul at Bingham Memorial, he does GreenLight laser photovaporization of the prostate. No one else in East Idaho, as far as I know. But I do know that in my practice, I perform more of the GreenLight laser photovaporization than anyone else in Idaho, and I'm quite proud of that. But to answer your question, Dr. Sisul and I both perform GreenLight laser photovaporization, and no one else in East Idaho, as far as I know.
Okay, that's great, Dr. Sissel. So I know you tied into this when you were talking a little bit about the GreenLight laser therapy, but let me just re-ask this question so we can just make sure that the viewer is addressed. I know that you said that the treatment or the therapy does not hurt, and usually the patient will not need pain management afterwards. But they said that the woman wrote in that her husband actually skipped an appointment out of fear that it would hurt. Does it, just to reiterate, does it hurt? And then she asks, what are the chances that it's unsuccessful?
Okay, great question. So no, it doesn't tend to be painful. Of course, some patients might have a poor experience and sort of relate an adverse outcome to another patient who is considering the treatment. But honestly, I have very good outcomes, and pain isn't one of the side effects of the surgery. I can tell you that. And So I'm sorry, I forgot the other part of the question.
They ask, and I imagine this will be individual based, but she asks, what are the chances it's unsuccessful?
Oh, great question. So Before we engage in a discussion regarding surgery or actually embark on doing the surgery, I fully evaluate the patient and with more than just a history and physical, but some imaging, and we come to the conclusion that this is right for the man. And so there's always the possibility with any surgery that a patient may not be improved. It's just sort of how life is. But for the most part, and this is why I continue to do this surgery and why my volume is so high, patients do very well. And so, if patients didn't do well, of course, the treatment option probably wouldn't be available. So quite a few patients do very well. So chances are this will be a successful surgery.
Okay, excellent. The next question that we have is, I am young, under 30, and I cannot get an erection. Is that normal?
So for the most part, no. The patient's age leads me to believe there's some other factors. It's not likely physiologic as far as the erectile function goes. This is likely something that's more psychologic. And so I would explore that with the patient to really pin down what's going on in that patient's life and what medications he might be on that might be affecting his erectile function. So no, that's not normal, and it's very correctable. So and the patient should feel that it's not likely something that's going to be lifelong, and he likely has a normal functioning penis as far as sexual function goes. So no, that's my answer to your question, Michael. It's not normal, but very correctable.
Okay, excellent. The next question that we have is, it takes me a long time to pee and takes a while to start. Should I be worried?
So, no, you shouldn't be worried. Shouldn't be worried about there being some sort of underlying medical problem that needs to be explored. Otherwise, your life will be shortened or something of that nature. As far as symptoms go that seem suggestive of prostate enlargement or BPH, which this scenario sounds consistent with, if the patient's bothered by his symptoms, if it's affecting his life, for example, if a patient really is getting up several times at night and is not well rested the next day and sort of can't perform at a high level at work or whatever he does, then that's when it's time really to talk about symptoms and treatment. But just having those symptoms sounds like there's some enlargement of the prostate going on. I would want to have a thorough discussion with the patient to get all of the background, but the patient shouldn't be concerned about some underlying medical problem just because of those symptoms.
Okay, excellent. The next question that we have is, I had prostate cancer about 10 years ago. I never had any symptoms then. What is the chance that the cancer will come back, and should I watch for specific things?
Right. Great question. So a patient who's had management of prostate cancer, which typically involves surgery or radiation treatment, is followed by typically a urologist after treatment to make sure there are no concerns about recurrence. So that urologist, and I have these patients all the time, and my father actually had prostate cancer, and I give him guidance regularly now that he's had treatment. But really, that patient should engage in a discussion with his urologist about the risk of recurrence. We have an idea about risk of recurrence after the treatment with pathology if it's surgery, and of course with PSA testing or that prostate-specific antigen testing that we continue to do after treatment. So that will give the urologist, who will then have that discussion with the patient about his risk for recurrence, and that he should be able to have his questions answered.
Okay, excellent, Dr. Sissel. What are the symptoms? I know you touched on this a little bit earlier, but let me just ask this particular question. What are the symptoms of an enlarged prostate, and can it be fixed?
Right. We touched on that earlier. I'm happy to go into it again. Symptoms, and a man shouldn't feel that he has prostate cancer because he has these symptoms. Prostate cancer doesn't typically present with symptoms, as I mentioned earlier in this webcast. But symptoms of having an enlarged prostate, which is typically what a man who, say, is 50 years or older has when he's complaining of urinary frequency, urgency, which is the need to get to the bathroom quickly, getting up at night on a regular basis, maybe even leakage when he can't get to the bathroom, having to push to empty his bladder, not emptying completely. Those are typical symptoms of an enlarged prostate, and it's a very treatable disease state. We typically have most of our success with medical management and then surgery. So it's a very treatable problem.
Okay, and then again, I know you. I just want to thank everyone who's been submitting questions and for being with us today. We're actually nearing the end of our live webinar, but still please continue to submit your questions. And if we don't get to them today, we will definitely be sure to, our social media team will track the questions in the comment section and submit those to Dr. Sissel. So we just have a few more questions, Dr. Sissel, before we run out of time. And I know you talked about this earlier, but at what age do men need a prostate exam, and they say that they also have no family history with cancer?
So the prostate exam isn't just to screen for prostate cancer. We also do it for men who complain of urinary symptoms that may be suggestive of BPH or that enlarged prostate. The exam can give us an idea about the size of the prostate. It can also give us an idea about whether the man might have something called prostatitis, which is inflammation or infection in the prostate. So I typically recommend the exam if a patient is coming to me with symptoms, urinary symptoms that are bothersome, like frequency, urgency, and he is, like I said, bothered by his symptoms. But then if a patient sort of meets those criteria for prostate cancer screening, yes, that's when I'll recommend the prostate exam also. And that one is more for detecting any nodules that might be consistent with prostate cancer. So there's no strict age when a man should have an exam of his prostate. Unless he's 55 or older and has no increased risk of prostate cancer, then yes, that's when it's time to do an exam. But if a man is younger than 55 and has symptoms of, say, frequency, urgency, symptoms that might be consistent with prostatitis, then I do recommend the exam. And then those men who have an increased risk of prostate cancer based on family history or ethnicity, then I will do a prostate cancer or a digital rectal exam prior to age 55.
Okay, excellent. The next question that someone has asked is, and we talked a little bit about GreenLight laser therapy earlier in the webinar, but this viewer has asked the question, I've heard of GreenLight therapy and water therapy. Which one works best?
Right. So the water therapy, I believe this person is referring to is called Resume. And what that involves is essentially steam therapy that is designed to be done in the clinic. And this is for men with bothersome urinary symptoms who say are not good surgical candidates or prefer not to go to surgery. The water therapy has some benefits. Of course, it can be done in clinic. In my opinion, it's not as effective as, say, GreenLight therapy. For men with urinary symptoms from an enlarged prostate, but it is an option for men. So when a patient comes to me asking about the different types of treatment, I cover them all. There are others, and I don't leave any stone unturned. I want a patient to have every option available to him and know that there's more than one option.
Okay, excellent. The next topic that I wanted to mention, is a lot of people may or may not know that they can see you for this, but something that I imagine that you do quite a bit is actually you perform vasectomies. Could you maybe talk a little bit about why someone would want to see you for that?
Sure. I do quite a few vasectomies for men who have decided that they don't want to they no longer want to build their family. I do them on a regular basis. My men have very good outcomes, and it's important to know. I talk to every man initially about whether it's the right thing for him, because it is meant to be a permanent result, meaning the man is going to be sterile. And so I want to make sure he knows that, because yes, there is reversal of vasectomy, and that is often successful, but it's not always successful, and it does involve surgery that not every urologist does, and it might involve an out-of-pocket expense. So I want to make sure a man knows up front what he's getting into, and to make sure that he and his partner have made the right decision to pursue, sterility. But I enjoy doing vasectomies. It takes about a half hour to do the procedure. It's an outpatient procedure. We actually do it in the clinic, as is most commonly done. The patient doesn't need a ride home, and he's actually back to work the next day if he wants to be. And we do perform what's called a semen analysis 2 months after to prove the sterility before I recommend the patient engages in sexual activity again.
Okay, excellent. And are there any common questions that you get from men before or when they're talking to you about contemplating having a vasectomy?
Yeah.
Are there any questions that you tend to get quite a bit?
Yeah, great question. Just to go back to my last answer, I allow men to continue sexual activity starting a week after the vasectomy, but they should consider themselves fertile until they have a negative semen analysis. So, and to answer your question here, could you ask it again? I'm sorry, Michael.
No, I was just going to ask you. I imagine that when men call you or when they come into your office for a consultation, I was just wondering if there are some common questions that you tend to get from men about what about a vasectomy or what it entails.
Right. So I cover everything when we talk about the vasectomy. We have a good discussion regarding what to expect. And I go through the procedure itself, kind of in a diagram. So many men will ask, will I have much bleeding? Will it affect my erections? Is there any increased risk of prostate cancer after vasectomy? And the answers are, the bleeding risk is minimal. I encourage them not to use certain anti-inflammatories right after the procedure, which can increase their bleeding risk. There's no link to prostate cancer development. There's no link to erectile dysfunction, because what we're doing is just cutting the vas deferens. We're not manipulating or damaging the nerves that supply men with erections, and we're not having anything to do with the prostate during that procedure. So those are not risks of a vasectomy. The vasectomy is greater than 99% effective. So, and the way I do it, it's kind of a belt and suspenders approach. I really want to make sure a man is sterile after the procedure, and so I'll do a few different steps to make that so, and we have good outcomes as a result.
Okay, excellent, Dr. Sissel. And something else that I wanted to ask you about, and maybe people may or may not know about this, is in what situation or why would someone want to come to see you for incontinence? Maybe you could talk a little bit about what incontinence is, and then why someone would want to see you to be treated for that.
Right. So for the most part, incontinence is a quality of life issue. Sure, there is a type of incontinence that is concerning, and that involves when a patient cannot urinate and is overflowing the urine from the bladder and is incontinent as a result of that, and the patient will often complain of leaking at night, large volumes. But that is all fleshed out in the meeting with the patient. But the other types of incontinence, which are urge incontinence, which is also called overactive bladder, and stress urinary incontinence, those are quality of life issues. They affect stress incontinence affects women, and if a woman is not bothered by her amount of incontinence, then nothing needs to be done. But if she is, of course, we can do something about it. As far as urge incontinence goes, that affects men and women, and it really doesn't necessitate treatment unless the patient's bothered. So these are quality of life issues that we can, of course, address and correct with the proper management.
Okay, excellent. And we're almost out of time, Dr. Sissel, but I do have one more question that I can ask is, what is a urinary tract infection? Are they common? And how would someone know if they potentially have a UTI or urinary tract infection?
Right. So a urinary tract infection or UTI is an infection in the urine. Typically, it's in the bladder. Most oftenly affects women. And it isn't worrisome unless a patient is getting sick as a result, developing fevers, having to be admitted to the hospital. That, of course, is concerning. But if a patient is having infections on a regular basis, then I'm sure that's affecting her quality of life. And so that's a good time to have an evaluation. But UTIs in general are common. Common symptoms are burning on urination, urgency, which is the need to get to the bathroom quickly, having to go often. Some patients can have bladder pain or pain in the pelvis, pain in their lower back. So those are common symptoms. Men can develop UTIs as well. It's much less common because of having a longer urethral length. But men can develop UTIs. Those symptoms are similar. And like I said, UTIs in general are common. They can affect quality of life, and that's when it's certainly time to talk to someone like me. And of course, when they're causing a patient to be admitted to the hospital, and that's a time to talk to a specialist.
Okay, excellent. And actually, I apologize. I said that was my last question. I have one more thing is I wanted to kind of clarify and have you elaborate a little bit on. As a urologist, for all of our viewers, that also I should also say that as a urologist, he is also a surgeon. So he performs surgery on a regular basis. And the one thing that I wanted to ask you about is I know that you're trained as a surgeon, you're trained on the Da Vinci robotic system. I just wanted to ask you maybe if you could talk a little bit about what that is, why that's a minimally invasive surgery, and maybe some of the more common surgeries you perform using the Da Vinci.
Yep, great question, Michael. So the Da Vinci robot has been around for greater than 20 years now, and we as urologists have sort of snatched it up and used it from the start, and so we're well trained in using the robot. It's a platform of laparoscopy that is ergonomic. So laparoscopy is surgery through small incisions with a scope and instruments placed through small incisions. A common laparoscopic surgery is gallbladder removal. And this is a form of laparoscopy, so it involves small incisions using a camera. But the surgeon is sort of at a console, which is a seat with a highly magnified visibility and screen. And we perform the surgery that way. The surgeon performs the surgery. The robot does not perform the surgery. The robot just assists with the surgery. And it's quite effective for our approaches as urologists. Pelvic surgery especially included in that is prostatectomy for prostate cancer. That's called a radical prostatectomy. There's also what's called a simple prostatectomy for men with enlarged prostates. I also use it for kidney surgery quite a bit, and that involves kidney removal for cancer, kidney removal for benign or non-cancerous reasons, partial kidney removal for cancer, also different congenital conditions, things that people are born with where they have swelling in the kidney and narrowing in the ureter. I use it for that approach. So it's very valuable to us in urology and in surgery in general. The general surgeons, gynecologists are using the Da Vinci on a regular basis. So it's wonderful technology.
Okay, excellent. Thank you again for elaborating on that, Dr. Sissel. Hope that's useful for any patients out there or even referring physicians throughout Eastern Idaho, just to know that you have a urologist that you can refer your patients to if they need any of those types of surgeries. So, Dr. Sissel, I'd like to thank you very much for joining us today and for providing some really useful information to Idahoans. I hope that that you've enjoyed yourself and were able to answer the questions the way that you wanted to.
Yeah, it's my pleasure, Michael. I've enjoyed the 6 years I've been here in East Idaho practicing, and I plan to stay quite a while in the community here, helping patients with urologic disease.
Awesome. Well, I know that you've helped a lot of people in the community, and that we're grateful that we have you as part of Team Bingham. I always like to end our interviews with the opportunity. We've been having this conversation today, and you've been answering a lot of really great questions. I was just wondering if during that time that we've been talking, there's anything else in general that you wanted to elaborate on, that you wanted to talk about with your practice, just to give you an opportunity to kind of have some closure to our interview.
Yeah, so we touched on quite a few things. We've sort of narrowed down what urology is and what urologists treat. We also treat kids. Kids have urologic disorders. I am rather focused, as I'm not trained in pediatric urology. I am an adult general urologist, but I do see and treat kids for certain disorders, common ones being undescended testicle, a boy needing a circumcision. So those are also, that's another patient population we take care of as urologists. So that's my answer to your question, Michael.
Okay, excellent. So we've reached the end of our Bingham Healthcare webinar. I just wanted to again thank you, Dr. Sissel, for being with us here today.
You're welcome. Thank you.
And just to reiterate, Dr. Sissel actually sees patients in both Idaho Falls at the Comprehensive Care Clinics off of Sunnyside right before Hit Road. And the phone number for his office there is 208-535-3637. Again, his phone number in Idaho Falls is 208-535-3637. And Dr. Sissel also sees patients in Blackfoot at the Idaho Physicians Clinic. It's at 98 Poplar Street in Blackfoot. And his phone number, if you'd like to schedule an appointment in Blackfoot, is 208-785-3800. Again, 208-785-3800. Again, thank you very much for joining us today. We hope that this has provided you with some useful information. And from everyone at Bingham Healthcare, we hope that you continue to stay happy, healthy, and safe. Thank you.